Hi, I'm Jeff Popma from CVN. I'd like to take about 5 minutes and review with you what I think is a critical component of our current strategies in interventional cardiologists, and that's understanding the care metrics that go along with our treatment of patients with acute myocardial infarctions. First, if it's important to understand that there's two pieces of information on the nomenclature. The clinical performance measures are those that are suitable for public reporting. That's how we're graded. And secondly, as part of these care metrics provided by the American College of Cardiology, there are quality metrics, and those are what we use for internal purposes to support the quality improvement programs that occur throughout our pieces. And you'll know that this is really part of a large series, as we talk about acute myocardial infarction, of performance measures that really span the broad spectrum of cardiovascular disease, heart failure, atrial fibrillation, primary prevention. Today we're going to focus on acute myocardial infarction, based on the recent publication online by Harlan Krumholtz, providing the 2008 performance measures for adults with ST segment and non-ST segment elevation myocardial infarction. Now, it's important to understand what ICD-9 codes are included. It's not unstable angina. It's only those patients who are admitted with the diagnosis of acute myocardial infarction, not those who develop it while they're in the hospital. It's a retrospective analysis, which means we have to get it right the first time. And these new performance measure criteria do align with CMS and the Joint Commission measures. It's important to understand that documentation by the nurses or by the medical students is not sufficient for these performance measures. Well, let's go through them. First of all, what's changed? Well, what's changed in the current 2008 performance measures is that the early beta blocker therapy requirement is no longer a performance measure because of the increasing complexity of early beta blocker administration. But aspirin on admission, aspirin prescribed at discharge, statins at discharge, evaluation of left ventricular function, and ACE or ARB for those patients with lower ejection fractions have remained a critical component of these new performance measures. In addition, now we have more definition of the time to reperfusion, both the optimal door-to-balloon time, but in addition, a series of requirements that document the door-to-door transfer time for our referring hospitals that send patients to us for primary intervention. The door-in, door-out times to understand the totality of delays in treatment of patients with myocardial infarction who are transferred for their definitive therapy. Aspirin cessation smoking is important. And finally, the addition of cardiac rehabilitation as a performance measure is a very important new piece to these new guidelines. Now, what's important to understand is there's a series of test measures that primarily relate to overdosing of heparin, enoxaparin, our glycoprotein 2B3 inhibitors, and it's important that each site develops their own anticoagulation monitoring and testing system to make certain that these errors in treatment modalities are captured. And finally, clopidogrel at discharge is now a test measure, particularly in those patients who don't receive a stent or don't have bypass surgery. So I think what I'd like to do now as we talk about the take-home messages is that there are important quality measures that are going to be part of our lives as interventional cardiologists. Beta blocker therapy is removed as a performance measure. Statin therapy is initiated in all patients with acute myocardial infarction, and there's more definition about those inter-hospital transfer delays with the addition of cardiac rehabilitation. These are very important to us. These quality metrics are going to improve the patient's outcomes tremendously, and I think that they're a good thing for us. But remember, these are our grades as we move forward. It's up to each interventional cardiologist to fully understand each one of these. What I'd like to do is I'd like to add someone who understands these data better than anybody else, Chris Cannon from the Brigham and Women's Hospital, as part of this CVN broadcast. Chris, these are important publications, I think, for all of us, as well as to interventional cardiologists. How do you put all this together in terms of how we as clinicians are now asked and graded on how we perform as clinicians?
Well, you pointed out very aptly that this really does speak to a need for a system, especially for monitoring the anticoagulation dosing. And so it will likely mean that we need to go back to our colleagues and divisions and set up a group to monitor how are we going to look at who gets what dose of heparin or enoxaparin. Is there renal adjustment for the 2B3A inhibitors? And this will take some work to begin to implement this.
Now, the other piece that's in here, Chris, which I think is fascinating, is now there are more metrics for the inter-hospital transfers that occur for primary angioplasty. You know, we're very happy when we're the receiving hospital and we have door-to-balloon times of 30 minutes because we're waiting for the patients to come in through the emergency room as part of their transfer. They come direct to the cath lab and onto our table. But that, of course, isn't when the patient first presents. Where do you think we're going with this inter-hospital transfer delay as part of a performance measure, and how do you think we'll use that information to guide patient care?
Well, it's a big challenge, and the American Heart Association is taking the lead, and ACC supporting it with Mission Lifeline to try and understand what are the time barriers, as has been nicely sorted through of the in-hospital phase. And a lot of it has to do with simply the ambulance transfer, and is there an ambulance ready to go? Are there delays, et cetera? Do people bypass the emergency department and go straight to the cath lab? And so sorting through those issues, again, now of a 2-hospital committee working group will be a challenge, I think, but an important one that will improve care.
I think that's key because now all of us are responsible as the receiving hospital for the time delays that occurs at our transferring hospital. And that puts a different incentive in terms of discussions that we move forward. One final point very quickly, statins mandatory now at discharge with the LDL cholesterol taken out of the performance measure and put into a test measure. Should every patient who comes into the hospital now with an acute myocardial infarction get a statin at time of discharge?
Well, I think we have good evidence that patients do benefit regardless of their baseline LDL. That had actually come in part from the heart protection study, but certainly from PROVE-IT and more recently the ARMIDA ACS trial, even starting the high-dose statin at arrival. And so all roads lead to statin therapy as an important component of care. And this performance measure will likely help us get to approaching 100% care.
Well, Chris, thanks for joining us. I think it's important that we understand now our performance measures for acute myocardial infarction. Very, very integral part of everything that we do. So thanks for joining us. From Jeff Popma from CVN, joined by Chris Cannon. Thanks for joining us this morning.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.